Welcome,
Hi, Lana.
everyone. Hi, Nikirote.
Can you
It,
hear me?
yes, loud and clear.
Awesome, awesome. I'm so sorry. Tech will be the end of us.
Well, thank you
Hi,
for
everybody.
thank you
Hi, Karen.
everyone for joining.
Hello.
Hi, hi.
Good
Hello.
afternoon,
Hi,
Charlotte. Where is
hello.
Charlotte?
For joining.
Charlotte has not joined. Is she not participating today?
Now, Charlotte will be joining soon, so let's hope she joins as early as possible.
Okay.
Yeah, let me just
Induka, good
okay.
afternoon.
Good afternoon.
Yeah, how are you doing?
How are you?
I'm
I'm
doing well. How's
Adamu.
the land?
Oh,
Yes, sir. My
You are
boss,
you are
I
in
miss
with
you.
my
you are in Mediguri, right?
Meduguri, for sure.
You didn't go to Thailand.
I didn't go. Maybe next time.
All right. Okay.
Um, Since we are there, I'm
okay.
highly represented.
It's okay. No problem. My committee is also there.
Thank you so much.
Well, it's great to see everyone coming back here again, and I'm gonna be putting in our check in. So let me just share my screen. As you know, we've started the check ins differently for each day. So I'm gonna present how is everyone arriving for today. And when we started Sunday, let's see. When we started Sunday, we did something unusual, and that was, let me put it in. We did this one, sheep scale. Um, we also did what's your internal weather like as a check in. And now I would like to ask, how are you feeling today? Are you ready for business? Are you focused? Did you wake up like this? It wasn't me, need a nap. So in the chat, just write down, are you 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, or 12? So that's the numbers that are coming in. Let's see. Ooh, 12, 2, 1. There you go. A 9, 3. Well, welcome for today's session. Just put it in, just for those who are also just coming in. How are you arriving for today's session? There you go. So many different ones. At least there's a lot of delighted. So I'm also delighted for everyone to be here. Uh, and we are now in our third session of the annual general meeting, CSIDNet annual general meeting. And we, when we started the sessions, we really focused on looking at data. And when we were looking at data, we said we need to make it in a, looking at data in terms of systems, in terms of ecosystems that are resilient and equitable. And yesterday we looked at policies and how it's important for it to be integrated, how policies need to be responsive, and how researchers need to be responsible in their role. And today our theme is around how can we be centering CSID community, equity, and engagement. And this is a very, very interesting topic, especially for me, since I'm very much involved within community weaving or community building, and equity and engagement activities. So I am very curious in terms of what is going to happen for today. For those of you who are new for today, although I do see most of the names coming in from the previous days already, again, we do have interpretation, French interpretation available. So feel free to click on the interpretation button so that you can access that. And like how we did it for the past 2 days. The format would be we'll have a plenary session and we'll also have parallel sessions happening. And this is going to be hosted by our chair, session chair for today, Dr. Nikirote. So I will be passing it on to you.
So, hi everybody. I'm also really excited to see the same names recurring because I was a bit stressed that everybody, like, fatigue comes in, um and it's really great seeing seeing new names, and it's also great seeing that we have people recurring and coming back and contributing. And I really, really hope today is going to be more energy. This is going to be mostly conversational. I always say there's no wrong answer. We have All of us have different contexts, so we all have something to contribute. And yeah, so welcome to day three, everybody. Today's theme is going to be on community resilience, equity, and engagement. And like Lana, this is something also very, very close to my own work and my heart. I am Dr. Kirata Kalaine, a medical doctor and health systems innovator based in Kenya. And I have been supporting the CSID Collaborative Committee, and I'm so honored to be here today. So, maybe to get us started, our theme today centers on human dimensions of CSID work. So, today we're going to discuss those who are most affected by climate sensitive infectious diseases. And we're going to discuss how they're also the ones that are least hard in policy, in science, in system design. And as we navigate the different sessions, breakout rooms, plenary discussions, I want us to have in mind some questions. How do we ensure equity in who is engaged and how do we shift power back to community? This is something that we've been discussing over the sessions we've been having in the past year or two, and especially in tool design, in research and response. Angela likes to say, how do we not become extractive? And today, we're also going to focus on the institutions and funding structures that enable these tools to be developed. And we want to know what must be changed or what can be changed for us to be more inclusive of community. So, who is most affected? And how do lived experiences shape research and responses? We want to discuss who sets research priorities and whose voice is missing. And we want to know, are communities passive recipients or active shapers of solutions? So, as Lana said, this is going to be interactive. We're also joined by a very great and powerful panel that are going to bring experiences across different disciplines. This is science, anthropology, policy, and community-centered program design. So I'll introduce them right before the plenary. But yeah, those are the things that I want us to mostly focus on today, Lana. Over back to you.
Thank you, thank you. Oh, it's so nice to see mostly the same faces that we've had for the past 3 days now. And I'm curious, before we get into the panel, I just want to hear a few voices. How has your experience been in the parallel sessions? Have you met new collaborators or people that you would like to get to know more in terms of their work? So anyone who would like to share, how has your experience been for the past 2 days of sessions? You can either unmute yourself or put your hand up. There are some people that I'm very interested to know. Dr. Ravi, how's your experience so far?
Hi, Lana.
Yes. Would you want to share how your experience so far is with the different parallel sessions that you've joined?
Yeah, thank you very much for giving me a chance. I have participated yesterday and day before yesterday, and I came to know more about the system. Although there are some confusing things, but I think I will get to know them today and tomorrow. So they were really interesting, and I came to know more about the database system and also the policy making and all these things. And thank you so much for making me participate in this the conference.
Yeah, thank you. Thank you for keeping on joining us. And who else? Who else would we like to share? How has your experience been? I'm curious to hear some more, but let me see. I'm how about you? How about you, Nice? How has it been in the different parallel sessions or even the plenary? I don't know if Nice can speak right now. We do have in the parallel sessions today, we do have two different topics that we would be offering as part of the parallel session and one question that can be explored. And so I would love to just invite first Adamo Saidu to share what is your topic about and what can they explore in your parallel session.
Okay, thank you, Lena, for this opportunity, and good afternoon once again. Yeah, compound to me if I'm audible enough.
Yes, we
Yeah,
can
you
hear
are
you
the
well.
Yeah, thank you. So for yesterday, that was day 2. I joined a PAL session that was having a team on integration of behavioral science and public health strategies. It was quite interesting, though we at a point in time we started not working like people like Samuel from eHealth Africa and the co-chair, that's Kemi. We discussed a lot. So all our discussions revolved around adaptation of certain strategies, things like improving vaccine acceptance, national policies, and how we can inform public health strategies by incorporating behavioral science. Just like so, we discuss around timing, ownership, leadership, building community trust and resilience to fight infectious diseases. So it was quite interesting. And could remember vividly, we discussed about C4D model, which is one of the behavioral change models in practice in West Africa, specifically Nigeria. It has proven to be very effective, meaning these are the things that you incorporate locals, meaning recognizing the local residents as major stakeholders in everything, every interventions. So that build trust, ensure relevance, and they will even give you full participation. So whatever you are doing or whatever intervention you have in mind, if you can achieve that, building trust, this is one of the great thing in most of the interventions. So this is what I wanted to say. And second thing, we also discuss a lot on participatory approaches, meaning things like focus group discussions with local people. So it's like a bottom top approach. You sit down with them, listen to them, know their problems, interact, you know. So this kind of behavioral approach or behavioral science in public health is quite interesting and we discuss a lot. This is what I wanted to say. And I'm happy. I learned a lot. Thank you so much, Lena.
Yeah. Adamo, would you want to share what you would be doing in your parallel session around your topic on infectious diseases in climate affected areas?
Okay, Lana, yes. My topic is on epidemiology of infectious diseases in climate affected areas. Yeah, so one thing I have in mind, these days, imagine zoonosis are everywhere. So the things I have in mind, things like climate change or environmental degradation, amplifies disease occurrence and risks, especially in climate affected areas like West Africa or where I came from, Nigeria. In recent time, there was a serious flooding that claims lives of human and animals. And as aftermath, there was an outbreak of serious outbreak of cholera. So I think the key things we need to discuss around is how climate change alters these transmission patterns, things like rising temperatures, increased rainfall, changing humidity, things like that, seriously affect the geographic distribution and seasonality of disease. Things like malaria, dengue, cholera that I mentioned earlier on. And of course, environmental degradation is also a risk factor, a serious one. Things like deforestation, because of the increase in population in West Africa, in Nigeria in particular, there are a lot of not spillover risks, meaning some are like water scarcity driven, deforestation. Most of them are revolving around the anthropogenic activities of human. That exposes humans and animals to come together and spillover pathogens happen. So I was thinking to prompt discussion like, so what is the role of environmental monitoring in this prevention? How can one LO interdisciplinary approach, be integrated into our common public health strategies of policies on ground, or how we
Mm.
can form the public health strategies on ground to expand to think ahead. Okay, we need to consider all these environmental issues, things around climate changes, because this is a reality that everybody is seeing. I can give you an instance now, like in Nigeria, we have a serious climatic change around rainfall. Before now, rainfall start early around April up to November, but now it has drastically changed. We experience rainfall around June now, and it stops around October.
Mm.
So the second thing, it comes with a high intensity or high volume to the extent that we every year we have like a minimum of 5 to 10 states being affected by flooding. And
Mm.
flooding comes with an outbreak of diseases. So this is a common problem around African country. I'm talking to my context where I came from, but I believe it's a common problem to West Africa, including Cameroon, because there was one river in Nigeria that passed through Niger, Cameroon, so we share common problems across
Yeah.
the line.
Adamu.
So
So we'll be putting you in room one so you can add some more to that later on.
thank you,
And so
thank you so much.
so for those who are interested in the talk around infectious diseases in climate affected areas, just know that it is in room one. Then we also have Musa who will be speaking around climate change, vector mobility, and reemergence of vector borne diseases. Musa, would you want to speak a little bit so we know what the topic is about? And because Musa will be speaking in French, so we will be, for those who want to stay in the conversation, stay in this main room so that there would be a direct interpretation that is happening. So, but first, let's hear it from Musa. Musa, can you share more about a little bit about your talk and about what you will be inviting them into a conversation with?
Bien sûr, Léna. OK, merci beaucoup, Léna. Donc, bonjour à toutes et à tous. Donc, aujourd'hui, nous allons discuter d'un thème d'une grande actualité scientifique et sanitaire, c'est-à-dire donc le changement climatique, la mobilité vectorielle et la réémergence des maladies à transmission vectorielle. Donc, comme vous le savez tous, donc les vecteurs, donc ça, les moustiques, les tiques et les mouches, donc sont très sensibles aux conditions environnementales. Or, donc, avec le réchauffement climatique, la modification donc des régimes de pluie et les événements extrêmes plus fréquents, leur répartition géographique évolue. Donc, certains vecteurs apparaissent dans des zones où ils n'étaient pas donc, présents auparavant ou bien prolongent leur saison d'activité. Donc, cette dynamique a un effet direct donc, sur la santé publique, c'est-à-dire donc elle augmente le risque de réintroduction de maladies comme le paludisme, la dengue, chikungunya ou encore la fièvre jaune, donc dans des régions jusque-là où peu exposées. C'est-à-dire que donc, ça peut aussi réintroduire donc, la maladie dans les zones de très faible transmission ou dans les zones où il n'existait même pas donc, de maladies à transmission vectorielle. Donc, de ce fait, donc, nous invitons donc les experts en climat, en santé publique et en modélisation donc pour explorer comment les perturbations climatiques modifient la répartition des vecteurs, comme voilà, les moustiques ouvrant la voie à la réémergence de maladies telles que, comme on l'a dit, le paludisme, la dengue ou la fièvre jaune. Donc, dans les zones épargnées autrefois. Donc, cette session donc, sera donc l'occasion de croiser les regards scientifiques, opérationnels et politiques donc, pour mieux anticiper les défis sanitaires donc, de demain à l'ère du changement climatique. Donc, je vous donne rendez-vous donc, ici. Donc, voilà en gros donc, ce qu'on va discuter donc, dans la session principale. OK, merci Léna, je vous retourne la parole. Merci bien.
Thank you, Musa. So we will be, for those who would like to have that discussion, just stay in main room, and then the third room, room two, we would be having a conversation that is facilitated by Nicarote. So would you want to share the question that we will be exploring in room two, Nicarote?
Sure thing. So in room 2, we'll be talking about money. We'll be talking about funding and incentives, specifically institutional incentives, and how they shape or limit how we engage communities. So throughout the days, we've been hearing communities are just or shouldn't be just passive recipients of data or interventions.
The only one who is unable to hear.
That they are knowledge holders, they're innovators, they should be frontline responders. And we also know that in many research and implementation models, community engagement is treated as like a secondary activity, something to do after things have already been done, after models have already been built, after funding has already been secured. And in a lot of times, that is not factored into the model. So in this section, we'll be exploring how current funding structures, institutional matrices, and research cultures either enable or constrain our abilities to engage communities meaningfully, because at the end of the day, these are the people we are building these tools for. And beyond critique, we'll aim to surface concrete shifts. So we'll be having discussions on what needs to change, where are better models already emerging, and how can we design for engagement that is equitable, sustained, and co-owned. And I think all of us in our different fields have experienced the effects and the impacts of the stop work order. And how do we still prioritize the people who need to be prioritized, even as funding is quite limited in our different sectors? So yeah, that's going to be the basis of our discussions. I'm really excited to hear what my colleagues have to say about that.
There you go. So I've put also here in the chat, main room is the conversation with Musa. We have room 1, we will have Adamo there, and then room 2 will have Nicarote. So we are following the law of 2 feet here, meaning you can feel free to join which room you would want to have the conversations with for the next 45 minutes. Just a little bit of sense making. If you see that there's more than 10 people already, maybe try to look at the other rooms as well, so that at least you can also have some space or voice in sharing your thoughts or ideas. Yusuf, are we ready to to open the breakout rooms?
Yes, sure. Thank you, Lena, for this work. the way we're labeling the room, so it's going to be more like a short form because the title page couldn't contain all the list. So we already know the room one is going to be about epidemiology of infectious diseases. Then the room two is for Musa on the on the topic, so which is going to happen in the main room. And then the room three is going to be on funding and institutional incentives, which by default is going to be room two, right? So I
Yes.
think that's all. So yeah, when we are ready, I think we're also ready to go from here. So over.
So just click on the breakout, and then underneath it, you can choose which room you want to stay. And also for our rapporteurs, feel free to then join the specific room. Dr. Ravi is.
Hi, Lana, there's no room for it.
Yes, so let me just put you in the breakout for those who need some support with that.
Is there anything I'm missing, Lena?
No, we're good. So Musa, I'm gonna give the floor to you. Let's wait for people to just um find their rooms, and then we can start in our room.
Okay.
Okay, so I think Musa, we're good.
Can I start?
Yes, let's go.
Ah, ok, merci bien. Merci d'être là, donc, à la salle principale. Donc, je me présente, donc, je suis Moussa Kane depuis Sénégal, donc, je suis doctorant, donc, en maths informatique et épidémiologie. Donc, je travaille, donc, sur la modélisation de comment comprendre la dynamique de la transmission du paludisme, donc, au Sénégal et en Afrique de l'Ouest. Autrement dit, donc, je travaille donc dans deux situations, c'est-à-dire dans les situations endémiques et dans les situations de faible transmission. Dans les situations endémiques, donc, j'essaie de comprendre donc, comment éviter, donc, comment ralentir donc, la transmission. Et dans les zones de faible transmission, donc, j'essaie donc de voir comment donc, éviter la réintroduction donc, de la maladie. Donc, autrement dit, donc, ça nous permet donc de lancer aujourd'hui donc notre thème, c'est-à-dire le changement climatique, mobilité des vecteurs et réintroduction donc des maladies. Alors, tout le monde sait que donc le changement climatique donc n'est plus donc un phénomène abstrait. Il est aujourd'hui donc une réalité tangible donc qui affecte directement la santé publique. Les températures donc plus élevées, les pluies plus irrégulières, des sécheresses et des inondations donc modifient profondément les environnements dans lesquels évoluent les vecteurs de maladies, c'est-à-dire les moustiques, les tiques et autres. Donc, ces transformations écologiques entraînent donc des changements dans la distribution géographique et la saisonnalité des maladies comme le paludisme, la dengue ou la fièvre jaune. Donc, dans des zones jusque-là considérées comme hors risque, deviennent progressivement vulnérables, tandis que d'autres voient leur fenêtre de transmission s'élargir. Donc, face à cette dynamique, donc une question cruciale donc, à nos chercheurs, à nos décideurs, à nos professionnels de la santé. Donc, nos stratégies de lutte, souvent fondées donc, sur des données historiques, doivent-elles donc désormais être adaptées aux projections climatiques futures? Autrement dit, faut-il ajuster nos campagnes de prévention, nos calendriers d'intervention ou notre allocation de ressources en fonction de ce que nous indiquent les modèles climatiques et épidémiologiques? Donc, la question que j'aimerais donc débattre ici avec les experts, c'est-à-dire donc, faut-il adapter les stratégies de lutte contre les maladies à transmission vectorielle en fonction des projections climatiques? Donc, je répète un peu la question. Donc, faut-il adapter les stratégies de lutte contre les maladies à transmission vectorielle en fonction des projections climatiques? Donc, la parole est à vous. Qu'en pensez-vous? Donc, quels bénéfices ou quelles limites voyez-vous à travers cette adaptation? Donc, voilà. Donc, je vous écoute.
Yeah, so feel free to unmute yourself if you want to share based from this question that Musa has posted in the group of how shall we adapt our strategies depending on climate change. Stephen or Charlotte or Peace, any thoughts around adapting strategies regarding climate change? Or perhaps Yusuf? Please, Charlotte, go for it.
Uh, Thanks. I think I'm going to speak in French for at least so that Musa will have another person that
Go
speaks
for
French.
it. Yes, go for it.
Ok, d'accord.
Merci, merci bien, Charlotte.
Merci Moussa. Donc moi, c'est Charlotte Mbou. Je suis du Cameroun. Je travaille avec la Fondation Apprendre Genève. Et je pense que je peux répondre à la question avec un oui. Donc les stratégies devraient euh, être adaptées. Mais dans un premier temps, il faudrait avoir suffisamment de données et suffisamment de certitude qu'en changeant les stratégies pour répondre au changement climatique, disons, par exemple, ici chez nous, nous avons constaté que le paludisme, à cause des changements saisonniers dont il n'y a plus une bonne maîtrise de la différence entre la saison des pluies et la saison sèche. Donc, auparavant, dans les années antérieures, nous étions sûrs des saisons de pluie et des saisons sèches. Donc, là où je suis, dans la région du sud du Cameroun, nous avions à l'époque 4 saisons dont on appelait souvent grande saison de pluie, petite saison de pluie, grande saison sèche et petite saison sèche. Mais aujourd'hui, ce n'est plus très clair. Donc, et c'est aussi le cas avec la transmission du paludisme parce qu'au moment où on se dit il doit faire être frais et que les conditions ne sont pas idoines euh, euh, pour la prolifération des moustiques, c'est là où il fait plutôt chaud et nous voyons qu'il y a plus de moustiques. Donc, ce changement-là. Donc, s'il y a suffisamment de recherches et suffisamment de données pour qu'on puisse développer des modèles clairs qui nous disent que voilà le niveau de transmission vectorielle par saison pendant cette période. Pour, par exemple, en termes de chimioprophylaxie, c'est mieux de distribuer les médicaments en telle période parce que c'est la période de forte transmission, ou bien c'est mieux de distribuer les moustiquaires imprégnés à longue durée d'action pendant cette période aussi. Donc, et donc, je vais vous renvoyer la question, est-ce que les études que vous avez faites ou bien les modèles que vous voyez, est-ce que ça prévoit à ce que on doit se pencher sur le développement des nouvelles stratégies? Mais juste pour dire, c'est oui si on a suffisamment de l'information pour justifier cela. Merci.
Merci bien, Charlotte, pour cette belle intervention. C'est-à-dire, juste aussi pour relancer aussi, est-ce que, donc, c'est-à-dire que quelles données seraient nécessaires donc pour, comme vous dites, pour avoir donc de la certitude? Par exemple, si on prend votre pays, Cameroun, Cameroun du Sud, comme vous avez dit, C'est-à-dire maintenant, quelles données seraient nécessaires pour cela, c'est-à-dire que pour avoir donc changé, adapté donc les modèles avec les changements climatiques.
Hmm. Très bonne question. Donc, moi, je veux penser aux données entomologiques, aux
Mhm,
données météorologiques, aux données épidémiologiques, donc c'est-à-dire les données de surveillance.
mhm,
Et on a la surveillance intégrée, donc c'est
mhm,
les données des mappés aussi.
mhm,
Donc,
mhm.
quoi d'autre? Bon, en tout cas, moi, je pense, donc données surveillance, données météorologiques, données entomologiques, je ne sais pas, dans un premier temps, si j'ai d'autres réflexions, je pense que je peux le mettre dans le chat.
Oui, oui. Non, non, c'est parfait déjà, c'est déjà bien, c'est déjà parfait. C'est-à-dire que la plupart des modèles, donc avant donc l'avènement donc changement climatique, donc la plupart des modèles paludisme, donc utilisés comme vous l'avez dit, donc des données entomologiques, des données parasitologie, donc très souvent. Donc c'est à travers ces deux euh, données-là qu'on utilise, deux types de données, pardon, qu'on utilisait très souvent donc pour développer des modèles. Et ensuite, donc, on utilisait, comme vous l'avez dit, donc, des interventions aussi, on modélisait un peu les interventions. Maintenant, face donc, au changement climatique, comme vous l'avez bien dit, donc, par exemple, si on prend l'exemple de Cameroun que vous avez cité, donc, il y a tellement de changements donc, de saison parce que vous avez dit qu'on ne parvient plus à reconnaître maintenant les saisons longues de pluie ou les saisons courtes de pluie. Donc, ça veut dire que réellement, donc, il faut adapter donc, nos modèles donc, face au changement climatique. Et donc, je suis d'accord parfaitement avec vous. Il faut donc, oui, il faut changer, mais aussi adapter aussi. Donc, euh, c'est-à-dire, comment je vais expliquer ça? Donc, c'est-à-dire que la collecte de données, effectivement. Donc, jouer aussi sur la collecte de données. Donc, intégrer donc les données climatiques donc dans les modèles donc, de prédiction. Merci bien, Charlotte. Donc, est-ce qu'il y a d'autres intervenants donc pour toujours continuer donc la réflexion donc sur ce sujet? Et même aussi, Charlotte a relancé aussi un peu le débat et on peut aussi même dire donc quel type d'intervention donc pourrait être aussi réajusté. Ça aussi, donc c'est peut-être donc une idée. On peut déjà élargir un peu donc dans ce thème.
Oui, et moi, je réfléchissais aussi en termes de intervention,
Mhm,
mais aussi acteurs, les acteurs clés, qui sont les
mhm,
intervenants. Et
mhm,
lorsqu'il s'agit déjà des interventions commençant par
mhm,
les enquêtes pour
mhm,
comprendre que jusqu'au niveau de l'implémentation. Donc, voilà une
mhm,
autre, peut-être pour élargir davantage
mhm,
le cadre de la conversation, si peut-être nous n'avons pas des experts en termes de modélisation et tout autre, mais on peut avoir
mhm,
des épidémiologistes, des
mhm,
membres de la société civile qui sont ici et qui sont aussi
mhm.
concernés par le sujet.
Bien sûr, bien sûr. Parfait, parfait, Charlotte. Si on peut prendre d'autres réactions.
And hi, Lana, I just wanted to be sure that the interpretation is working.
Yes, I can
Okay,
hear it well.
okay.
OK, super.
Because and I just wanted to say, so let me just speak in English for a moment, maybe to um just cast the net a little bit wider for because like malaria is one of it's still like the first cause of morbidity in sub-Saharan Africa, and I know that many of us here uh have a personal, I don't know, experience. Maybe we have seen a loved one, a family member that has suffered from malaria, which is a vector-borne disease and thus a climate-sensitive infectious disease. And so, if it could be interesting to hear some, how has maybe in your context, just from your own observations, the transmission in malaria changed over the course of the years in your context. You can share that with us, and it could be a cause for research or surveys to really find out if there is a need for change for re-strategizing when it comes to how we prevent or how we tackle the fight against malaria in our context. So it will be good to maybe hear from all the other colleagues that are in the room.
Yeah, Sam, Moses, Fahoni, Dancina, Stephen, curious or nice. Any thoughts that you would like, or Bella, any thoughts that you would like to add?
Alors, en attendant qu'on ait des intervenants, par exemple, dans le cadre moi, de ma thèse, donc, vous savez qu'ici au Sénégal, donc, la cartographie donc, du paludisme se divise donc, en trois parties. Donc, au nord, donc, on a une zone quasiment donc, de très faible transmission. Donc, quasiment, il n'y a plus de paludisme dans le nord du Sénégal. Au centre, donc, on a des zones, des fois, de hotspots, mais la plupart des centres, donc, on a des zones aussi de faible transmission. Maintenant, c'est le sud du Sénégal, particulièrement trois régions du Sénégal. Du sud qui sont donc en frontière avec la Guinée-Bissau, la Guinée-Conakry, voilà, et un peu le Mali. Donc, ce sont ces trois régions-là donc, qui sont des zones de très hotspots. Donc, les zones où on a donc plus de cas de paludisme. Et dans ces zones-là aussi, c'est des zones aussi très pluvieuses. Alors, donc, dans ma thèse, donc, j'ai utilisé donc des données climatologiques donc, de notre centre de climatologie ici, donc l'ANASIM. Alors, on a comparé un peu, donc, on a fait une étude, quoi, donc étude comparative, c'est-à-dire on a cherché un peu la corrélation, si je peux m'exprimer ainsi, entre donc les composantes climatiques, à savoir donc pluviométrie, température moyenne maximale, moyenne minimale, humidité maximale, humidité minimale, ainsi de suite. Et on l'a donc comparé avec donc, les cas de paludisme. Alors, on a trouvé que donc, c'est l'humidité qui influence le plus donc, sur les cas du paludisme. Autrement dit, bien vrai que c'est une zone pluvieuse, mais la pluie donc, n'interfère pas directement donc, dans les cas de paludisme. C'est-à-dire, mais c'est-à-dire que les précipitations donc, entraînent très souvent donc, des flaques d'eau et au-delà, donc les entomologistes savent un peu de quoi je parle. Donc, l'environnement donc, est un peu propice au développement des vecteurs. Donc, ainsi, donc, maintenant, puisque maintenant on est dans un contexte de changement climatique, donc c'est-à-dire que maintenant les pluies donc, deviennent de plus en plus rares, certes, mais quand elles arrivent, très souvent, donc c'est à une grande quantité, donc c'est-à-dire avec des inondations. Donc, c'est-à-dire que donc il y aura toujours des flaques d'eau qui vont rester donc pendant des jours, des semaines, voire même des mois. Et ça, donc, ça contribue un peu donc à la prolifération donc, des moustiques, des vecteurs dans le cas du paludisme et d'autres vecteurs aussi. Donc, ceci dit que donc, ça va créer encore quelques donc, mobilités vectorielles, donc facilitées donc, par le réchauffement global, donc, qui va permettre donc, à certaines espèces vectrices de coloniser donc, de nouvelles zones auparavant non endémiques. C'est-à-dire que donc, l'urbanisation aussi donc, est aussi, donc, je sais pas, un facteur aussi donc, qu'on va aussi tenir en compte parce que les changements climatiques aussi vont contribuer aussi donc, à la population donc, de migrer un peu dans des zones aussi voilà, non favorables vers des zones aussi pas favorables. Donc, j'aimerais bien aussi qu'on exploite aussi un peu cette piste pour voir aussi donc, quelle idée donc, ça pourrait sortir dans ce cadre. Voilà.
Thank you very much, Musa. Hi, Mercury. I'm curious if you were able to follow. Oh, no, Mercury was out. There's a question that's coming up for me, and I don't know, Musa or maybe Charlotte, the two of you. Um, I like the framing of what's good enough for now, safe enough to try. So in this question that you've posed, Musa, around adapting our strategies depending on climate change, I'm curious in terms of, yeah, but what's good enough for now, safe enough to try in terms of changing our strategies? What have you seen that has worked well that others can adapt, or perhaps experiments that others can do in this in this direction of shifting strategies?
Ok. Ce qui a fonctionné, bon, par exemple, si on prend donc le cas du Sénégal ici, par exemple, alors donc les modèles mathématiques donc ont beaucoup contribué donc à la réduction donc des cas de paludisme ici au Sénégal. Donc les programmes nationaux ici qui luttent contre le paludisme s'appuient très souvent avec les chercheurs, les universitaires, donc et utilisent leurs modèles donc pour lutter un peu contre la propagation de la maladie. Par exemple, les SMC, donc en 2012, par exemple, l'OMS, par exemple, donc, a déclaré qu'on peut donc élargir un peu les SMC. Les SMC, c'est-à-dire donc on administre des médicaments des enfants de 3 mois jusqu'à 5 ans. Mais en 2012, l'OMS a dit que maintenant on peut élargir les SMC jusqu'au niveau de 10 ans. Et cette étude a été menée ici au Sénégal avant d'être adoptée par l'OMS. Donc, cette étude a été menée ici au Sénégal, à l'Université Cheikh Anta Diop. Donc, ça veut dire que donc, les modèles donc, qui étaient là, qui existaient, donc, ont largement contribué donc, à l'éradication du paludisme. Et ça, c'est juste un exemple. Alors, d'autres exemples encore sont là, par exemple, les MDA, donc la distribution de masse, donc, a été aussi adopté ici. Bon, a été adopté ici au Sénégal aussi, mais aussi c'est grâce aux chercheurs aussi donc qui ont travaillé donc, sur des modèles de distribution de masse. En effet, pourquoi? Parce que le paludisme, il a été constaté que le paludisme, en réalité, maintenant, ce n'est plus les cas cliniques qui posent problème, mais c'est plutôt donc, les porteurs asymptomatiques. C'est-à-dire que les porteurs sains, mais qui développent le parasite à l'intérieur. Et c'est-à-dire que maintenant, lorsque un moustique pique un humain sain, mais porteur de gamétocytes, donc ce moustique-là, en retour, devient donc malade. Et peut, pas malade, mais ça devient infecté et peut transmettre donc la maladie à d'autres personnes. Donc, puisque maintenant on ne sait pas donc qui est porteur sain et qui est porteur, voilà. Donc, on essaie de développer aussi là, et ça fait partie aussi dans le cadre de ma thèse, donc un modèle mathématique avec la distribution de masse des médicaments. Donc là aussi, à la fin de la thèse aussi, donc si c'est validé donc par les pairs, par le jury, donc ce modèle-là aussi sera aussi pris en charge donc, par les programmes nationaux de lutte voilà, et peut-être même pourquoi pas vers l'OMS. Donc cela montre un peu pour répondre à votre question. Donc ça veut dire qu'il y a beaucoup de choses qui ont fonctionné. Et normalement, donc pour les visions même de l'OMS et des programmes de recherche. Donc, normalement, on devait être en 2025 à la phase d'éradication même du paludisme. Mais compte tenu maintenant avec quelques perturbations, surtout peut-être liées à la pandémie de COVID-19, donc il y a eu donc quelques perturbations, donc voilà, et la maladie donc a refait surface dans quelques jours. Mais heureusement, ici au Sénégal, dans notre cas, ici toujours, donc on est en phase presque pré-élimination dans la plupart des cas. C'est comme je l'ai dit, c'est juste 3 régions du sud donc, qui sont donc des zones de hotspots. Et malgré qu'elles sont des zones de hotspots, c'est juste un cas très faible, c'est-à-dire des cas inférieurs à 5 pour 1000. Hein. On est dans des cas inférieurs à 5 pour 1000. Mais si on prend dans le cadre Sénégal, donc ces 3 zones-là donc, sont des zones de forte contamination. OK, donc c'est juste pour répondre un peu. Donc ça veut dire qu'il y a beaucoup de choses qui ont fonctionné, donc des modèles qui ont fonctionné et que les programmes et que l'OMS même a validé et que ça a permis d'éradiquer un peu donc, la transmission du paludisme. C'est pas ce que les autres en pensent.
Thank you, Musa. I'm curious, Charlotte, from your end, are your thoughts?
No, I just think I find it very interesting how far they have gone in Senegal in terms of like um they are already pre that is in the pre-elimination phase. And I wanted to find out from Musa, has climate change been able to impact, like, are they observing, because he mentioned that maybe they got a little bit delayed because of COVID-19. But I wanted to ask, because what we is happening in some places is that some diseases that were almost being eliminated are re-emerging because of the changes in the climatic conditions. So I just wonder if is that the case, was that the case in Senegal, or the delays that they have experienced is mainly because of the COVID-19 pandemic?
Merci bien, Charlotte, pour cette question. Merci bien. C'est-à-dire que, effectivement, la question que vous abordez là, donc la réintroduction des cas de paludisme dans les zones de préélimination, donc c'est un thème même, je ne dirais pas que c'est la question de recherche fondamentale de ma thèse, mais donc ça en fait partie. Donc maintenant, j'ai inclus dedans, comme vous avez dit, les changements climatiques, avec donc un dérèglement climatique, donc tout le monde est d'accord, qui existe là et qui est tangible maintenant. C'est-à-dire comment donc maintenant éviter la réintroduction du paludisme dans les zones de très faible transmission, compte tenu maintenant avec les changements climatiques observés.
Ah,
Effectivement,
d'accord.
voilà. Donc, mhm.
C'est très intéressant. Et il y a aussi la question que je me posais, parce qu'il y a cette question d'attribution, que parfois on voit des zones où peut-être il y a des problèmes de carnivaux, donc des problèmes d'urbanisation et d'urbanisme qui font en sorte que parfois, parce que les égouts ne sont pas bien entretenus, lorsqu'il y a pluie, il y a une inondation. Donc, on va voir que peut-être que dans certaines circonstances, on peut attribuer des situations au changement climatique, mais pourtant, c'est peut-être que des questions liées à l'urbanisation ou bien ou d'autres faits humains, quoi, dont mauvaise gestion des ordures, par exemple, des actions. Donc, est-ce qu'il y a possibilité de connaître la différence entre ce qui est attribuable au changement climatique et ce qui est dû aux actions humaines? Donc, en tout cas, en vous écoutant, beaucoup d'autres questions me viennent à l'esprit.
Bien sûr, bien sûr, bien sûr, bien sûr. Non, ça c'est très pertinent, c'est très pertinent. Ça veut dire que, comme on dit, les gens ont l'habitude de dire, donc le paludisme, donc c'est-à-dire que la transmission, donc il y a plusieurs facteurs qui interviennent. Par exemple, le comportement humain, comme vous avez dit, donc le comportement humain, donc c'est-à-dire l'urbanisation et changement climatique. Mais par exemple, si je prends le cas du Sénégal, hein, que je maîtrise mieux, donc
Oui.
l'urbanisation pour le cas du Sénégal, ça ne pose pas pour le moment un problème majeur. Parce que la plupart des cas que nous observons ici, les cas de paludisme que nous observons ici au Sénégal, donc c'est des cas qui nous viennent donc des régions un peu rurales et non des régions urbanisées. Donc si ça nous vient des régions rurales, donc cela signifie que donc peut-être que l'urbanisation dans le cas du Sénégal, hein, n'a pas un grand effet par rapport à la contamination. Donc, la région du sud que j'ai énumérée, donc c'est des régions peut-être voilà, rurales ou semi-rurales. Et là-bas, donc, le PNLP donc, a mis un dispositif très intéressant, c'est-à-dire qu'il y a ce qu'on appelle donc les PKDOM, donc les prises en charge à domicile. C'est-à-dire qu'il y a des villages qui sont un peu éloignés un peu, du centre-ville. Donc, on prend donc des volontaires donc, qui vont sillonner au niveau des villages. Lorsqu'il y a un cas, rapidement d'aller détecter le cas et de mettre un peu en quarantaine, si je peux m'exprimer ainsi, donc tous ceux qui sont un peu proches du malade. Et régulièrement, ils viennent voir un peu, donc la famille, les proches, est-ce qu'ils ne sont pas aussi un peu, est-ce qu'ils ne présentent pas des symptômes et autres avec les TDR, les tests de diagnostic rapide. Donc ça, c'est un fait. Donc, pour lutter un peu donc, contre la propagation de la maladie, ça s'est mis en place par le PNLP. Et autre chose encore, bon, comme on a parlé donc aussi de la raréfaction, je ne sais pas, donc de la rareté des ressources. Alors, comme par exemple, si on prend donc les SMC, donc là, c'est-à-dire que là, on distribue donc des médicaments aux enfants de moins de 5 ans et l'OMS avait élargi jusqu'aux enfants de moins de 10 ans. Alors, avec la rareté maintenant des ressources, moi-même personnellement, on a développé ici donc un modèle pour comparer un peu, donc c'est-à-dire la transmission vers les enfants de moins de 5 ans et les enfants de plus de 5 ans, c'est-à-dire pour voir un peu coût, efficacité, efficacité et coût. OK?
Ouais.
Voilà, et il est ressorti que dans le modèle, peut-être qu'il sera publié très prochainement, qu'il n'est pas nécessaire d'élargir, donc dans le cadre sénégalais, ensuite, il n'est pas nécessaire donc d'élargir donc les SMC jusqu'aux enfants de moins de 10 ans. Si on se limite uniquement aux enfants de moins de 5 ans, donc les simulations ont montré que donc on peut éradiquer le paludisme. Ça, c'est peut-être donc un papier qui sortira bientôt, quoi. Donc, en gros, pour répondre en gros, donc, comme vous l'avez dit, donc, il y a le comportement humain, il y a donc les changements climatiques, il y a donc voilà. Mais en gros, nous, on retient qu'ici, donc, au Sénégal, donc, l'urbanisation donc, ne joue pas un grand rôle donc, dans la transmission. C'est peut-être un peu donc changement climatique, voilà, et peut-être les conditions environnementales parce que ce sont des zones rurales qui influencent un peu donc la transmission. Et ces trois zones aussi sont des zones très pluvieuses, comme je l'ai dit au début. Donc ça, voilà, donc c'est la raison pour laquelle donc peut-être un peu on constate toujours des cas. Et autre chose aussi que peut-être que je pourrais aussi dire, c'est-à-dire que ces trois zones-là, j'ai dit que sont des zones limitrophes, pays Guinée, Bissau et Guinée-Conakry, qui sont des zones maintenant très endémiques.
Mm.
Donc là, voilà, donc là aussi, donc peut-être il y a ce qu'on appelle paludisme d'importation aussi. C'est-à-dire que des gens, bon, qu'on a diagnostiqué de l'autre côté, Guinée-Bissau, Guinée-Conakry, et qui migrent, qui arrivent au Sénégal peut-être pour se soigner ou bien pour d'autres choses. Donc, c'est pourquoi donc, ces trois régions-là restent toujours des zones un peu endémiques dans notre pays. Donc, voici en résumé un peu ce que je pouvais répondre là. C'est pas ce que les autres en pensent.
Merci beaucoup, Moussa. C'est très clair pour moi. Et une chose que je retiens aussi, que nous avons commencé
Mhm,
à voir depuis hier, en tout cas depuis le
mhm,
premier jour de cette rencontre par rapport déjà à l'importance des données. Et puis hier, on
mhm,
regardait un peu le côté gouvernance et les systèmes politiques. Et on a dit, donc moi je pense qu'une chose qui fait que peut-être le Sénégal soit un peu du lot, c'est
mhm,
l'engagement politique, donc la volonté politique vraiment à lutter contre le paludisme, ce qui fait en sorte que déjà, il y a cette collaboration intersectorielle qui
mhm,
amène à ce que les stratégies soient mises en œuvre pour lutter efficacement contre le paludisme.
mhm. Bien vrai, bien sûr, bien sûr. Donc, il y a une bonne politique de l'État aussi contre, voilà, contre la transmission du paludisme. Donc, l'État donc, joue un rôle extrêmement important donc, dans la lutte contre cette maladie. Donc, c'est l'État donc, qui gère un peu. Donc, il y a plusieurs instituts donc, qui luttent contre la transmission de la maladie. Et ces instituts sont donc sont renforcés, donc sont aidés par l'État, même s'il y a aussi d'autres partenaires à l'extérieur. Mais l'État donc joue un rôle fondamental. Donc, l'État est le principal bailleur. Et ça, c'est vrai. Donc, l'État joue un rôle important dans la lutte contre le paludisme. Ça, c'est vrai.
Yeah, I find this question very powerful. Well, also this inquiry, Charlotte, that you've um, added in around political engagement. I do know that in any change, political will and political engagement is very important because it drives policies, it drives action, it drives, of course, power and resources. And in the spirit of the today's theme around community engagement, you've also shared about the importance of intersectoral collaboration that's already happening, right? So it's like on that level of intersectoral collaboration, there's already things that are happening. And so I'm curious in terms of your experience, Charlotte, around that political engagement. What do you think is lacking in that regard?
Okay. Thanks, Lana. And before I talk a little bit about that, I wanted to pull out something that Musa said that to me was quite remarkable. That is the home-based treatment, what is called pecadom in French. That's home-based treatment of malaria, which is done by community health workers. That's community volunteers that have been trained, so that each time they detect a case, they have to put the person separately and then treat immediately. And that is something that is talks about community engagement in relation with what we are seeing today, but also connecting it with political will, because for those community health workers to be motivated enough to go to the field, they need incentives. So it has to be incentivized. But one thing we have been looking at since the start of these virtual events was that no matter, how good our data is, no matter how performant the models and the tools we develop are, if we don't have the policies in place and if we don't have the governance system to be able to use this, then there will be no difference that is made. And I know that in my context in Cameroon, a lot has been done. And before you asked me that question, I was going to ask Musa, what is the situation? I don't know if the malaria vaccine has been introduced in Senegal, but in Cameroon we have, depending on the geographical zone, because Cameroon also is distributed like in three geographical areas. We have the Sahelian, that is in the northern parts of the country, and then we have the grass fields, and then we have the tropical zones. So, and in the northern parts of the country, because malaria is transmitted seasonally, uh, so they have what we call, that is seasonal chemio prevention. So they administer malaria treatment to prevent transmission in children of a certain age. So that political will, it is there. But I think what is the most often the limiting factor is resource constraints. So it's resource constraint. So what we try to do, talking about my organization, is we engage with frontline health workers. So we have a network where they are able to share what they are doing in their context, what actions they are taking in their context to address the challenges that they face in the fight against malaria. So like educating communities, like cleaning, emptying stagnant water bodies around the environment, education around the use of insecticide treated bed nets. So there's really a more of a focus on number sensitization and community engagement, how to engage key community stakeholders to get them to educate their community members and families on how to better fight against malaria. But one thing that is also worth noting when it comes to political will is actions that are taken to reduce the cost of malaria treatment. So like in our context, treatment of malaria is free of charge for children under 5 and pregnant women. So just to show that some of those actions are being taken by the government, even though they may not be enough, but it's worth highlighting that when there is political will, a lot can be done.
Yeah, I'm just also putting in what Sam has shared. I don't, Musa, if you can check in the chat. From an AI developer perspective, the fight against malaria is hampered by a lack of good data sets that can be used to develop AI models. Data protection laws also present challenges, preventing the use of data sets across different jurisdictions. Digitization of health records is lagging behind in many African countries. Even when digitization has occurred, patients are unable to access their data held across various hospitals.
Yeah, that's quite interesting, Sam. I think it's very true because one of the things that we have heard from funders about malaria is the fact that the data is, even when the data at times is available, it's not reliable. So you look at like data in terms of, if you're looking at treatment data, diagnostic data, and all of that, it doesn't really you don't see how it follow through. It's not really reliable. And maybe Musa can tell us a little bit from the Senegalese experience, how they have been able to manage this, especially as they have developed a good number of models around malaria. So maybe Musa is better placed to comment on that.
Par rapport à la fiabilité des données, quoi.
Oui, parce qu'il y a le commentaire de Sam dans le chat qui parle de l'utilisation de modèles de l'IA et aussi le problème de
Thomas,
digitalisation des registres de
ah
santé.
non.
Oui, donc
Oh,
c'est un peu
lui,
ça.
le fait.
Please, can someone mute
OK,
Steve?
Yeah,
OK,
muted now.
OK. Merci bien, Charlotte. Donc, oui, oui. Donc, je vois un peu, donc, vous avez parlé, donc, d'utilisation de l'IA, donc, dans les modèles. Ensuite, donc, de la fiabilité des données. Et Léna même, je crois, a parlé aussi de vaccins, je ne sais pas, l'introduction des vaccins et autres. Alors, donc, pour la fiabilité des données, bon, je prends l'exemple sénégalais. Alors, nous, nos données, alors, proviennent donc du PNLP, le Programme national de lutte contre le paludisme. Et le PNLP nous fournit donc des données, euh, de très bonnes données, des données de qualité. Donc, et puis, non seulement c'est des données de qualité, mais c'est des données aussi que je peux dire transversales. Donc, on a des données des enfants de moins de 5 ans, on a des données pour les femmes enceintes, on a les données c'est-à-dire de tous les individus confondus. On a aussi des données supérieures à 10 ans. C'est-à-dire que euh, le PNLP classe les données donc d'une façon vraiment qui permet aux chercheurs donc d'aller très vite. Et c'est des données fiables. Et parallèlement aussi, il y a le DIH2, donc du ministère de la Santé, qui nous fournit aussi les mêmes données, quasiment. Donc, ces données-là et les données du PNLP, c'est quasiment la même chose. Et c'est des données très fiables. Donc, ce qui fait que nous, ici au Sénégal, donc, on n'a pas de problème de fiabilité de données. Maintenant, pour l'IA, donc, voilà, vous savez que je suis dans le consortium, donc, WAMCAD et MARCAD. WAMCAD, donc, c'est un consortium donc, de modélisation mathématique pour l'Afrique de l'Ouest, donc, qui regroupe cinq pays, dont le Sénégal. Donc, il y a Ghana, il y a les deux Guinées et il y a le Nigeria, dans WAMCAD. Maintenant, au niveau des doctorants aussi, donc il y a certains aussi qui se focalisent uniquement donc, sur l'IA. Comment utiliser les données et utiliser l'IA donc, pour éradiquer un peu le paludisme. Mais moi, bon, comme l'IA, ce n'est pas un peu ma spécialité, donc, voilà, donc je ne sais pas exactement donc, ce qu'ils font là-bas, l'IA. Mais ce que je peux dire, j'ai eu à discuter avec donc, quelques experts en IA. Et donc, il y a une localité, par exemple, là où je travaille, zone Cœur Saucé. Donc, il y a un institut, Marcat, je crois que même Cameroun, vous connaissez le Marcat, n'est-ce pas, Charlotte? Malaria Research Programme, qui est plus vaste que le WAMCAT. Donc, le Marcat donc, réunit l'Afrique de l'Ouest, l'Afrique centrale et je crois un peu l'Afrique de l'Est. Donc, ce programme aussi, donc, ils ont donc un dispositif de collecte de données, des données entomologiques, des données parasitologiques et des données environnementales. Donc, on a eu à discuter donc, avec des experts en IA pour voir maintenant avec les conditions donc, environnementales, c'est-à-dire les gîtes larvaires qu'on observe dans cette zone-là. Et donc, la collecte des données donc, mensuelles donc, des vecteurs. Alors, ne serait-il pas possible, donc, avec ces données-là, d'anticiper un peu donc, maintenant sur des modèles qui pourront détecter de manière précoce donc les cas de paludisme. Donc ça, donc on est en train de réfléchir sur ça. Donc c'est un modèle donc on est en train de réfléchir. Donc ça a été financé. Donc voilà quoi. Et concernant maintenant pour le vaccin, donc il y a l'Institut Pasteur ici au Sénégal, donc qui travaille dans le cadre des vaccins. Mais pour le moment, c'est pas encore intégré ici au Sénégal. Mais ils sont en train d'y travailler, de voir maintenant comment installer un peu donc, le vaccin RTAS donc, dans certaines localités comme la région du sud du Sénégal, qui est donc une région endémique. Voilà un peu en résumé donc, ce que je peux dire sur les questions là. Charlotte,
Ah, merci beaucoup, Moussa, c'est clair.
merci bien.
Thank you, everyone. Let's wait for everyone to come back in. Okay, Nicarote, I'm handing it over to you.
Hey,
Lana,
hey.
how did you
I'm
cut us? We
still.
were having our meeting and it was interesting. You just cut us off.
I had to side chat Lana and tell her, give us 5 extra minutes. We were really, really having a great time in there. And I can see we're not the only ones. So maybe we should take a few minutes just
Yeah,
to summarize.
I didn't notice that 45 minutes.
Yeah, they just flew
Yeah.
by. I feel like we even just now started like the core of the conversation. So maybe Lana next year, we need more time in breakout rooms, so that we can really, get in there. So guys, we have a few minutes to learn from each other, and we are going to take turns, and this can be either representatives from each group or whoever was chairing the open session to just give us a summary of what you guys discussed. What did you learn? What didn't you learn? How was it? Tell us. And Lana, I think it would be you do me a great service if you're to introduce the other two, and then I can finish with my
Yeah, so
breakout room.
we
Yeah.
can start first with Musa's
Sure.
room, which was in the main room. We were talking about climate change and yeah, who would like I think either Musa or Charlotte is best to share what transpired
Uh,
in your room.
can I share like from my side?
Ravi, we'll do Musa's room first and then in
Okay.
your room.
Okay.
Musa or Charlotte, would you want to share what happened in the main room?
Oui, d'accord, bon, je vais essayer. Alors, donc, dans la salle principale, donc, le débat était passionnant. Donc, comme l'a dit l'autre là, donc, même les 45 minutes là sont passées très vite. Donc, dans cette session, donc, on a d'abord donc, souligné un constat donc, largement partagé, c'est-à-dire le changement climatique modifie donc, les conditions écologiques de manière significative. Donc, affectant la distribution, donc, la densité et la saisonnalité donc, des vecteurs comme les moustiques et autres. Donc, cela favorise l'expansion donc, géographique des maladies telles que le paludisme et autres. Donc, l'idée principale, donc, c'était donc comment adapter un peu donc, les modèles donc, et intégrer le changement climatique pour prévenir un peu la réintroduction donc, de la maladie dans les zones de très faible transmission ou dans les zones qui étaient même voilà, hors maladie. Et donc, on a échangé sur les données. Donc, Charlotte a fait donc une brillante donc, intervention et a parlé donc beaucoup sur le cas du Cameroun et a montré aussi quelques défis donc liés à ce pays. Et aussi donc le problème aussi de la fiabilité de données et le problème de l'introduction donc des vaccins au niveau du Cameroun et un peu le changement climatique donc, qui affecte un peu donc, le Cameroun. Donc, ça a déjà une perturbation Oui, donc il y avait une perturbation donc un peu au niveau du Cameroun, donc c'est-à-dire que les saisons des pluies ont un peu changé, donc ça c'est lié donc au changement climatique. Voilà, et on a abordé aussi donc le cas du Sénégal, donc le cas du Sénégal, donc la transmission au Sénégal, donc qui est donc une zone donc presque donc de faible transmission, à part donc quelques poches qui restent encore toujours des zones endémiques. Donc on a aussi parlé un peu des perspectives, donc comment introduire l'IA donc dans les modèles pour prévenir un peu, donc pour anticiper un peu donc sur les transmissions. Voilà en résumé un peu donc ce qu'on a échangé ici dans la session principale. Je ne sais pas, peut-être que j'ai oublié quelque chose, peut-être Charlotte pourrait ajouter un peu. Si... Voilà. Donc en résumé, c'est ce que j'ai un peu retenu ici. Peut-être que Charlotte va augmenter un peu pour voir est-ce qu'il n'y a pas des détails ou Lena, il n'y a pas quelque chose que j'ai un peu omis là. Voilà, merci bien.
Yeah, maybe just to add one thing to what Musa shared that stood out to us from the Senegalese experience was the strong political will. That is the intersectoral collaboration when it comes to actions. That is what research institutes are bringing out as results and how it's been taken up by the Ministry of Health, other partners to leading to change to policies that are put in place in the fight against malaria. And one other thing I wanted to talk about was that he said actually they are in a pre-elimination stage of malaria in Senegal, but they are trying to do studies now to see if climate change has taken them backwards as far as that is concerned. And I think that is very important because um, um, because it could be they could be making wrong assumptions that it's the COVID-19 pandemic that maybe drew them backwards. Meanwhile, it's climate change. And the last thing is the use of community health workers for home-based treatment of malaria. I found out to be very valuable and important, especially as we are talking about community engagement and equity today. Thank you.
There we go. And then we have
Super.
from room two, we have in Adamus room.
Yeah, thank you, everyone. Good afternoon. Thank you for meeting me once again. So we had a wonderful discussions. However, I wanted to join Ikorote on the request that we need more time into break sessions next time because we are in the middle of we are enjoying the discussions. All of a sudden, we found ourselves in another room. So thank you for this. So we had a wonderful discussions around two questions like the biggest challenges we have in our surveillance system, a country-specific approach. So we had shared experience from Nigeria, from Philippines, especially those communities in Nigeria and also in Philippines that are prone to outbreak of cholera, malaria due to climate changes. So the issues we discussed a lot of things. So it like a Nigeria and Philippines share common problem, like they need funding in strengthening their surveillance system and responding to disease. And somebody suggested the incorporating early warning science system into our surveillance system is another way in order to improve our surveillance system and tackling or early detection of infectious disease outbreaks with regard to weather-driven data we have. And at the same time, we discuss issues around inaccessibility, the insecurity in some regions, especially in the conflict-affected areas. At the same time, they have serious climate changes coupled with the insecurity. So we cannot reach out to these people. We don't have data. It's a serious problem in Nigeria as well. And of course, we face a serious challenge in data falsification. Many people will give you data anyhow because you can't reach that area and you have no any other option. So, we need data to predict outbreak and to make policy decision. So with that, we can say the policy decision making process is seriously in a dilemma because you are making decisions out of false data. So it's a serious concern, and we need to work on that. Then we also identify one common gap to Philippines and Nigeria also, which is a surveillance system at community level. It's very full to all, and with only that, until we strengthen our surveillance system at community level, that will give us early detection to detect and as well as early response to those issues. So I think I will give room for other members to share more like Aliu and Heidi, I mean, from Philippines, because we had a discussion before now and you just cut it off. And I don't know, they feel bad. I'm saying sorry for that. That's why I put some comment on the chat for them to respond to their comments, the chat session for guidance. So the last but not the least, we discussed about the bureaucracy. So bureaucracy is a big problem and it's a big challenge in both countries because a lack of integration of or data harmonization is a serious one because there are policies that you cannot give data to other organizations or to other. So with that, detection of early signs of diseases before the outbreaks or before things get out of hand is very difficult in countries like Nigeria as well as some part of the Philippines. So these are the things we discuss. And we also discuss about the problems like yeah, flooding and increase in rainfall intensity in some part of Nigeria, especially the far northeastern region. In recent time, they have flooding and that resulted to serious outbreaks of cholera, malaria. This is as a result of increased abundance of mosquito populations. So similar scenarios happen in Philippines, of which theirs is not malaria. They had a serious outbreak of dengue. Dengue is also an arbovirus and a serious one. So as a solution, Heidi pointed out one important thing, which is an integration of the stakeholder engagement, whereby in their own case in Philippines, Ministry of Health and Weather Department get together, means they collaborate by integrating temperature data into health-related data to predict dengue outbreak, a kind of one health multifaceted approach, and it worked for them according to her. So this is a lesson learned for Nigerians. I think we can adopt this. We are good to go. So I like the networking and even me sharing this session. I learned a lot from the people in my room. So frankly speaking, I was enjoying the discussion. To be frank, before it. So I would like to give a chance for other people in my room to say one or two things on this line. Thank you, Lena, for giving me this opportunity to share the session, and thank you, Ikroti, and over. Bye.
Thank you so much, Adamo. I think the petition has been had for longer breakout rooms discussions. We also had the same issue. If you gave us an extra hour, we would have probably now been more satisfied. So I was in breakout room 3, where we're talking about community engagement. And I don't want to be the one to give our debrief. So I'll ask one of my members. So Dr. Ravi, Sadiq, Mr. Nduka, I'd love one of you to jump in and tell them what we were so passionately discussing.
Sorry, I said I was driving. I'm not sure if I can be able to contribute right now.
That's fine. Dr. Ravi?
Looks is muted. We can't hear you.
Dr. Ravi, we can't hear you. I don't know if you can. I can see you're not on mute, but we can't hear you.
Now,
Yes.
can you hear me?
Yes.
Okay. Thank you so much, and sorry for the inconvenience. what we have learned is that we have to deal with the community in a proper way. And also, there were some difficulties even in Nepal. I have told about that one. And I have also learned the many things from other part of the countries, maybe like Nigeria. And I think in developing countries like Nigeria, Nepal, everything is similar, not totally similar. And we were talking about the committee engagement in the north and south aspect is different. Also, like I have learned that we have to deal with the community members in a proper way, and we have to be fully prepared before going there. And also, we have to have like some the documentation programs before reaching the committee, and after the program is over also, and they will be they will participate nicely and like in a more precise way. uh, I
Okay,
think I
sorry,
can say.
I have to park to
Yeah.
respond. Thank you so much. I'm sorry. I have to park somewhere because I'm passionate about this community engagement and I need to put our discussions forward. We talked about designing program from the beginning. The moment you have identified what you want to do, the moment you have identified the program, the intervention you want to do, because you have already been in that community for some times, you don't just go into a community you don't know and then begin to tell them that what you want to do. You must have operated in that community for some times, and then they have developed trust in you. So engaging them will not be too difficult. And we're talking about in terms of funding. So engaging them to carry out activity will not be so difficult because they already know you. And then we also talked about, apart from what Doctor has said, we also talked about sustainability plan. If they are involved or if they were involved from the designing of the program, you tell them, look, this program is going to run for 1 year. After 1 year, the people giving us money will not be able to give us money. But we want this behavior change to continue. How do we make sure that this behavior change is sustained after the intervention? They will tell you from their own perspective, and then you build on that. Somebody talked about strategic communication, that we don't actually, that it needs to, it's a process. Strategic communication is the process. It's not something you don't plan before going there, because you also have to monitor the outcome of that communication and how that intervention is going to impact in the community. So, Doctor, sorry, this is a little bit of what I have to add into that discussion. I'm sorry I have to pack to make this contribution. Thank you.
Thank you so
All
much.
right. I don't know if thank you, teammates. I don't know if there's someone else who would like to jump in. Sadiq, do you want to? Oh, fantastic.
Yeah. So I just pick in from what our colleague has said to really stress it. And the learning component of the community is what I really stress a lot more. That as much as we're involving communities today, we need to continuously involve them right from the start, even during implementation, and learning to iterate how we implement programs across all levels. And that is a cornerstone of sustainability or building things within the community structures. We cannot develop solutions in the office and expect that community will adopt them wholeheartedly. We have to put them in the process, listen to them, and most importantly, our community-led and our community-led initiatives or community-led strategies need to be evidence-based, and any data we collect, even from the communities, a scientific and very objective approach to really guide, even to guide the traditional structures, to guide the civil societies. It has to have some database, and that's where we come in, contributing to the right set of data in an objective manner so that any intervention you're planning is not what we feel should be done. It's what the community actually needs because we actually listen to them. Thanks.
Thank you, Sadiq. So that was discussion room 3, and everything that has been mentioned here, we linked that up to what are the barriers to this community engagement, because we identified the importance of the community. So how do we how do we, or we, let me say not identified, but we also discussed the need for ensuring that this community engagement is factored in the budgeting process of what that looks like. We talked about a few barriers that we do have when it comes to funding. So all the way from funding cycles to political climates and social norms, religious beliefs that can affect that funding. But we also talked about what needs to shift. So, what is our role as the people who are grant writers, program managers? What is our role in ensuring that the appropriate funding is allocated for us to continuously engage, to continue this trust process, to ensure that the community leaders, institutions, or members are adequately incentivized to be able to push for the things that we are looking to actually change in the communities. And that was us. Lana, I'm so sorry, we are a bit over time, and we're a little bit over time. So I don't know if you'll give us a few extra minutes during the break, so that you can go
Yes,
grab a glass of water.
definitely,
Yeah, but thank
definitely.
you.
So
Yeah.
we'll have about 10 minutes of break before we proceed to the plenary. And for those who would still want to access our virtual expo, feel free to join the High Hive channel just to go around, look at what's already there, the videos and the resources that are there. So we'll see each other in 10 minutes.
All right.
So I would like to invite everyone back in. I do hope that was enough of a stretch for you to get water or just do some stretching or some dancing with the music. Passing it on to Nicorote for our plenary session.
All right, I can see we're all back. Good morning, good afternoon, good evening, everybody, from wherever we are. So welcome to our plenary, and this is an important plenary sessions, and we're going to discuss the meaningful engagement of end users in climate-sensitive infectious disease modeling and tool development. And we've been talking a lot about the intersection of science and community and policy, and now we need, or rather, we're going to shift the discussion towards how do we ensure that the powerful models and tools that we are building are not just technically sound, but they are also usable, that they are trusted, that they're also, and this is where we're talking about community, they're grounded in the lived realities of those most affected by climate-sensitive diseases threats. So in today's conversation, we will explore how we engage the true end users, and highlight that true end users of these tools. So here we're talking about public health officials, we're talking about community leaders, frontline government analysts, but also we're discussing like who are the true end users. So talking about these parties as active collaborators in their design, implementation, and evaluation, but also the people who are going to be affected. So we'll be asking, how can the people who model or how can modelers work in deeper partnerships with communities, not just as beneficiaries, but as co-creators? We're going to discuss what does it take to really build tools that don't sit in dashboards or reports, but that actually inform action. And how do we handle something particularly complex in that we need to foster trust and informed decision making rather than just fear paralysis. So this session is about shifting from extractive to collaborative models of knowledge, ones that value both scientific insight and local expertise. And we want to be able to see how we can build bridges between the people who model, so the people who are creating, and those who respond to them, our end users. And today we are joined by an exceptional panel of experts. I've had the privilege of interacting with some of them briefly, and panel of experts who each bring unique perspectives from research, implementation, policy, and we will be having these discussions and they'll help us dig into not just what is possible, but also what is practical and what is necessary if we are to build something that, or things that are resilient, equitable, and responsive to climate sensitive diseases. So I think people always do a great job at introducing themselves, and I hope they're not going to be modest during their introductions. And if they are models, I'll jump in and add some fluff. So today with us we have Professor Helen, who will still introduce herself, but just in brief, she is a professor of parasitology at Keele University, and she co-leads the ECLIPSE project to reduce stigma and improve care across care access for cutaneous leishmaniasis in Brazil, Ethiopia, and Sri Lanka. We will also be joined by Mr. Sadiq Wanjala, Malaria Program Manager at Clinton Health Access Initiative in South Africa, where he supports malaria elimination strategies across Southern Africa and leads knowledge translations for, I don't know if it's MMALA or MALA, a capacity building program training for PhD students across Africa. And we will also be having Dr. Camille, who is a research scientist at the Cypress Institute, where he develops climate-sensitive mathematical models for vector dynamics and disease transmission. So welcome to you all. I will start with you, Professor Helen. I will start with you. Welcome.
Thank you. So what would you like me to?
I'd like with you to maybe just give us a bit more context on the work that you do, but also like, why are you here? Why CSID network? What sparks your interests? Tell us a little bit about yourself.
Okay, so I'm a parasitologist by training. About 5 years ago, I started a big grant that was funded in the UK. And it was a collaboration between myself and a medical anthropologist. So I'd worked on leishmaniasis for years, but at the parasite level, and I'd never really thought about people. So we developed a big project. We were working in Brazil, Ethiopia, and Sri Lanka. So we had a country lead in each site. And we were looking at stigma and patient journey. So it really, for me, it gave me a completely different perspective on a disease that I thought I knew about, but I didn't really. So I'd not really thought about treatment access or mental health conditions or anything to do with the parasite. Leishmaniasis is it is linked to climate change, but we have very little data on where it is, and that I think is a big problem. We don't have the baseline data, particularly for cutaneous leishmaniasis. There are big areas where we don't know if people are infected. So climate change, I think, it's a big issue, but it's going to be difficult to model.
All right. So you said something so interesting, and it's also something that maybe from a personal experience led me to moving from clinical practice to what I do now, where it's very easy to look at a patient and just see their disease, right? And you've talked about stigma and mental health attached to the disease itself. So my first question to you is, how does the community that sees leishmaniasis beyond just the disease, how do they define healing beyond treatments, based on your own interaction with the community now? How do they see the disease and healing of the disease beyond treatments? And here we're talking about now the climate elements. Do they recognize that when it comes to the other levels of support that your organization does and your projects have done? How do they define healing?
It depends on the country and on the context. I think for Brazil, we found that the awareness of the disease was quite high. We were working in an area that was it was highly endemic, but it has been for a long time. There's good data, and people know that it's a biological disease and where to get treatment. In Ethiopia, we're working in Tigray, and during the course of the program, there was a war there for 2 years. So we were also working in a war zone, which was really challenging. Stigma there was huge, and I think there was a concept that the disease is not biological, and it's either a curse from God or it's genetic. So I think the whole perspective from the communities was very different, and treatment was just not offered. People would go to the primary healthcare centre, and there was very low awareness of what the disease was. So there was no real functioning referral system for people to go to the hospital for treatment. So it's very difficult to compare the different sites because they were just very different. But I think that on the healing side, I'd always thought as a parasitologist, the healing is when all the parasites are gone. But in reality, it's much more complex than that. And for example, for children, they may lose a year of education because they're taken out of school, and that can have a big long-term effect. But I think one thing that really struck us all was the level of self-treatment. And there are so many stories and myths about leishmaniasis. Even in the area where there was a treatment center specifically for CL, people would self-treat first. And I think we have to think about that when we're developing interventions, that we can't ignore community beliefs and perceptions. We have to integrate in with that, because they just won't be accepted otherwise.
Okay, and you worked across geographies. So we're talking about Sri Lanka, Brazil, Ethiopia. How have you worked with local communities to co-design stigma reduction intervention in those endemic regions? What were the specific things you did in terms of engaging the community, so that it is very, because you said it's different, right? It's different in Brazil and Ethiopia and Sri Lanka. So how have you worked with those local communities to co-design stigma reduction, and also to sensitize them on the climate element of the disease, that it's not genetic?
So when we wrote the grant, we were going to do the same thing in all countries, so that we could compare them directly, and that we didn't do that because it just wouldn't have made sense. One thing we did do right at the beginning, and I think this was discussed earlier, we set up community advisory groups. So this was done by the local teams who first approached community leaders and talked about the project, and asked people what they wanted us to do. And we set up a group in each of the field sites. So we had 3 field sites at least in each country, and we had a group in each. And the people who were on the groups were recruited in different ways in the different countries, depending on what the advice was. So, for example, in Ethiopia, there was a public vote on who would be representing them. And then we had, then the pandemic hit, because we were working in 2020. And in Brazil, the community groups met online and got to know the researchers that way. In Ethiopia, it was less of a problem, but then the war was later on. But the groups helped us to develop what the methodologies would be, and that really helped to give ownership to the project. So yes, it's been incredibly useful, and then the groups helped to get recruitment for the project as well.
Okay, so basically that's the upside of how you engage the community, using advisory groups, community leaders, being context specific in how you engage. And I think I'd also like to, for the sake of the group, what are the challenges when it comes to community engagement? Which engagement model or field experience really challenged your team's assumption about what meaningful community engagement and leadership looks like when it comes to specifically to CSID work?
I think for me, I think it was the time that was needed to really develop relationships. It's not something that you can do in a week. And as a parasitologist, I think I would have gone into the communities, asked questions specifically on leishmaniasis at the beginning. And the groups that we had, particularly in Brazil, the leader, Lenny Trad, had been working in anthropology for years and had used lots of different creative methods. and spent months really developing relationships with the groups. And then the other teams used her work as an example, and then brought those methods into theirs. So I think it's the time that really it takes a long time. And there was the groups were dynamic as well. So some people would leave, some people would join. In the different cultures, we had more groups. So from Sri Lanka, for example, we set up a women's group because the women weren't talking as much, and having the dynamic, so you don't just have one person who's leading the group and nobody else is saying anything is important. We had external challenges. We had the pandemic, we had the war in Tigray, we then had an economic crisis in Sri Lanka, and all of those have been really difficult to work with. The community groups that we set up in Ethiopia were actually really useful post-conflict, because they advised us on when it was appropriate to start the research again. And we didn't know if people would want the team to go back, because they'd been through a terrible conflict. But because of those relationships that had been set up, and they'd gone to visit, they were called sympathy visits, and they were just to see if people were okay, and not to talk about the research, but to just touch base and make sure that people were okay and they were still there. But I think having a lot of input at the beginning really helped. And we also had an impression at the beginning that we used the word empowerment in the title of the grant. And we reflect on that now, that you can't just go into a community and say, we're here to empower you. We're going to help. And people were already empowered, but they needed links. So, for example, in the rural communities in Brazil, they were really neglected in access to healthcare, but they found it really difficult to talk to politicians because the politicians were not going there. So we introduced the members of the group to local health ministers, and then they didn't need us to introduce them. They were perfectly okay to have meetings themselves, but they just needed that link. So I think we realized that it was, we'd assumed a lot of things at the beginning that were probably not.
I love what you just said. Like, they didn't need empowerment, they needed links and access, right?
Yes.
And is it safe to say, at least from what you're saying, that the success of the program was like the community engagement and the community push was an integral part of it, especially when it came to the challenges that were outside of your control, such as war and economic, a pandemic. Is it safe to say that?
Yes, I think so. And ownership, I think so. We had a team meeting in Sri Lanka a couple of years ago, and the team had been working really closely with some high school students, and they'd set up what they called health clubs, and they were not just talking about leishmaniasis. They were talking about lots of health issues generally. And we got to the school, and they announced they had a surprise for us, and they'd set up a whole street drama, and they'd done the scripts and the costumes, and they performed this for the whole team, and we had no idea that they were doing it. And that was mind-blowing that they'd done that. So I think, but
That's really great.
It felt like the community were owning the project. So they were doing things they're not telling us, and that's how it should be, I think.
I think we are speaking the same things we've been speaking in our different discussions, because I saw Sadiq smile when you said timing as a challenge. It's something we had discussed even in terms of funding and ownership,
Yes.
buy-in from the community, so that you can be able to push. I'm inviting questions, guys. I'm inviting questions in the chat. We'll go through them at the end, so that we can at least get to hear from all our speakers. Thank you, Professor Helen. We'll come back to you. Sadiq, hi. How are you?
I'm fine, and Kirote, and thank you, Prof, for a very brilliant submission as well. It's quite insightful.
All right, Sadiq, it's your moment to not be modest. Give your very extensive, introduction, and then I'll start with my questions.
All right, thank you. I'm Sadiq Wanjala. I'm from Kenya, but I work in South Africa. And I always talked of malaria as a lived experience because I had malaria so many times. And right now I'm working to eliminate in geographies in Southern Africa. And that's what I've been working with from the department side, trying to build strategic plans that are evidence-based driven. And that has led me to really writing regional grants, right from Mozambique, covering Mozambique, Eswatini, and South Africa, together with the National Malaria Elimination Strategy for South Africa from 2019 to 2024, and currently 2025 to 2029-30 periods. And just to extend that, I work on the nexus of many different partners, right from academic institutions, with climate scientists, mathematical modelers, and policymakers, really to try and bring a connect of transdisciplinary research, of which is much needed in this area. There's no field that can claim to have full expertise by themselves as one person. It needs us to really work together. And just going on by some of the comments, including community organizations into the structure right from the start go, because these are the elements that we really build around that. Just to go, how I was also introduced to CSID is through a similar engagement last year during the Climate Health Africa conference, whereby I was there representing the University of Cape Town with Clinton Health Access Initiative, just discussing around the projects we have in developing a CSID tool and taking it to build a community of practice around getting a data tool that brings all these sources of data across policy, disease intervention, and also the environment part in one portal for ease of access for all end users, including researchers and students. So that's currently my brief background. I'm very passionate in M&E components and learning components. So anything that I do that I believe can show us some learning aspects and iterative improvement, I'm always for it, because we can only get better through a learning experience. I hope I have tried my level best to say
A little
something.
bit. All right. So, in your work advising governments, and your work spans across like multiple stakeholders, and you're developing these tools with all these stakeholders. How have you seen CSID tools serve? So part A is serve or exclude important end users. So community health workers, patients themselves, the community, and that's part one of the question. So how do these tools serve to exclude or serve? How do these tools serve or exclude important end users? And can you share a case where a tool was adjusted or improved to better reflect the needs of those who are often overlooked? So, and here when we talk about those who are often overlooked, we know it's the patients and the community.
Yes.
Yeah.
So for this question, I'll start off from giving an example of one of the work streams I've supported since 2019, and primarily was to build an information system that would assist the national department to have real-time data for all the malaria cases, so the malaria surveillance and response system, and was built at the backbone of the DHIS2 system. And in this toolkit, the end users are the data capturers, or the people at the ground level, in the field level, to really use this tool to capture the tool and ensure that every data that is collected, not in a paper-based system, but in a digital system, and can be integrated into the system. Most of important is how they served the need was first, we looked at how the structure is. In South Africa, they have a three-tiered system. They have a two-tiered system, national and provincial. All these provinces have a very different context. One province will take up the intervention, in this case, the surveillance system, and the other provinces will come in at their own pace, and they'll all need different inputs at different times. The biggest challenge part was how to consolidate all of this while maintaining inclusion of all provinces. I.e., will all provinces move at the same time? Will other provinces move slower? And how do you make sure that they all move with the same structure? So in attempt to ensure that it serves their needs, the first component is always collaborative workshops from the ground go. I.e., you sit down with them, work through the internal flow processes at the lowest level of the end user. And in this case, we're talking of the data capturers. We are talking of the environmental health practitioners at the ground level. We're talking of the district managers, and talk to them. What happens when a malaria is reported as per your current provincial system? After that, you go to the next province, which is, say, KwaZulu-Natal, Mpumalanga, or Limpopo. Go to the next process, do the exact same procedure, and ultimately come up with a consensus-reaching system, so that whatever tool you decide to aggregate into a digital system is actually inclusive to serve both sides. So I think that part was really critical in developing the MIS system in South Africa. And it reached a point of whereby we are now able to do an Android phase in which we are now trying to take it to the digital field. At that point, it is still challenging, because when you have now to include this, and this is where the exclusion part comes in, when you have to include the frontline workers, there's a cost element first, there's a technological gap next. These system challenges. When we were doing the Android rollout of the DHIS2, of which we had no choice, because COVID had told us you cannot go out easily, you cannot go to the office, so you needed digital systems to continue working. And we had to roll out the tablets and the digital Android system to the frontline health workers. There you are, and you require, it's not syncing to the server, it's excluding them using the system. But the catch is, we need to be able to iterate the tool, ensure that the tool is able to adapt to the provincial realities, and most so secure the funding needed to support the systems. And all of this was actually motivated to be funded by the domestic funding, which was actually a big plus. So any of those tools that we had to build to serve the systems were actually built with the departmental funding at that point to really roll this out.
I'm seeing a question here that is relevant to what you're speaking of.
Sure.
So I'll ask it on behalf of Claxton Wisdom. As digital technologies become central to CSID tools, how can we ensure that the design of these technologies account for digital literacy gaps, language diversity, and infrastructure challenges, particularly in underserved communities across West Africa, to avoid widening the inequalities we aim to address? And I think the tool you're talking about has a very specific end user, right? But we have tools that cut across. So based on your own experience developing tools and being in the front line of building information systems, how do you address those challenges to avoid widening the gap further?
So the first component of designing any tool or designing any intervention, and in this case, let's say a CSID tool, I'll give an example, e.g. of the tool that we've developed with UCT, which is called Health Radar, is really defining who your target person is and your end users or who is this tool supposed to be used by? If you're building a tool that needs to go to the public, if you're building a tool that needs to do social listening, if you need to build a tool that needs to educate the community members right from a young age to an elderly age, then what requirements do we need of the tool? At this point is whereby I come to the conclusion that we need to use technology in an ethical sense, i.e., the use of AI in an ethical sense can allow you to include diversity within the tool to learn that it can translate to any language automatically. It can be able to be inbuilt. When we are building the CSID tool, which is a radar tool, tries to put the data together, you can build a system that allows people to engage with the tool at their level and not necessarily having to have the level of capacity or knowledge to use the tool. The other component to really ensure that is you build a community around the tool to make people feel included in the process, not actually feel, to make people be included in the process so that they're able to ask and freely share what gaps are they having to access the tool. So the catch about the diversity, I think there's the other part around digital literacy gaps. What capacity
Yeah.
building tools are you actually planning in advance of your tool that will not hinder people from accessing your tool? Good example, we know from a research perspective or a tech perspective, they all like GitHub. They all like R code. They all like all this big Python. But the people we want to use this tool, will they be able to use all these tools effectively? My question is yes.
Yeah.
Ethical use of AI can allow them to break it down, and building the community of practice and community of experience around these tools will allow us to take it to the last mile. And
Thank
around
you.
infrastructure challenges, I think that's a difficult question, but more on choosing the right technology in the right context. A good example is in South Africa, when we were developing a tool to enable 24-hour notification of all cases, we do not have internet connection around all facilities, but a USSD code proved to be the trick, whereby a free USSD code was developed, and this was at the community, at the NAS, at the community hospital of clinic, just with the community, with a code *834#, with the code of the hospital and the name of the patient. That information came straight into our MIS system and it was integrated. We removed the technological barrier of having 3G or a smartphone just by choosing the most appropriate technology and ensuring that we take that to the last mile as well.
Thank you. I can see questions coming up, and I will shelve those for now so that we can go through our discussion. And if we have some time at the end, we'll definitely come back to them. And so, Sadiq, one of the things we're doing within the network is we have fellows. We have a group of 5 fellows currently doing different projects globally in different countries. And a big part of this is community building, right? And you have the MALA, MMALA. How do you call it? MALA?
It's
Have I said it correctly?
it's Mathematical Modelers Analytics Leaders for Africa.
That one.
Yes.
So we have that program that builds capacity in PhD fellows. How are these fellows being equipped to ensure that their research outputs become usable and relevant, and not just for policymakers, but for frontline implementers or even community level? Is that something that is being addressed during the fellowship, or everybody gets to figure it out on their own?
So I'll give a little background history on what MALA and how we conceptualize it in 2022. When a capacity grant was discovered, or a gap was discovered, mathematical modeling as a tool is very relevant and has been used in really advising national strategies. And for instance, South Africa, we used a mathematical model to really convince the department, it was supported by CHAI at the time, to actually fund, to do a domestic fund, conditional grant for elimination. And even WHO acknowledged it, saying it's very novel because we're able to use local data, using mathematical models to show where we need to fund to drive elimination. So, but the question is, what are the capacity gaps on mathematical modeling? So when we drafted this grant, Chai came in with a specific role, as I work straight with the policymakers, in ensuring that when we are enrolling the students, they went through an interview process. I was part of the interviewees. And my question was super simple. What is in your national elimination strategy? What do you know about it? And after that, it was an issue around their first workshop was I taking them through how malaria planning happens. And the next step we did was to do an introduction through an advocacy group, which connects all the ministers of health in the countries these students are coming from, to discuss policy relevant issues with the countries. So critical to the students and creating such fellows is ensuring that you do not engage policymakers after deciding what your problem is, after thinking through what mathematical model you're doing. And I'm not a mathematical modeler. My first statement to them on a workshop was, explain to me your mathematical model, how you'd explain to your mom at home, or explain to a district manager, or explain to a policymaker who has 10 minutes of your time. And it's only these communication workshops and engagements I do with the students that allow them to communicate back and forth with their NMCPs, because we link them with the NMCPs to really develop questions that will address their national strategies. And right now we are pushing to them to actually having working arrangements with the NMCPs as part of their learning experience. In turn, we really hope to have a system whereby they're able to understand a mathematical model is good, but it's only as good as it comes with an implementation plan of the scenarios you're going to present. If you end with a mathematical model, well and good, we'll give you the degree, but at implementation level, we will not even understand where to start.
Yeah. All right, last one. Are you able to share an example where, not are you able, please share an example where data, community engagement, and policy design were aligned? Because you said you work with all these different stakeholders. So where did this align? Data, community engagement, and policy design were aligned in a way that advanced resilience at the community level.
So when I thought through this question, I looked at the examples, and some of the examples I might even pull in is from different contexts, because previously the most interesting part, one of the jobs I did before even this one, was an M&E of saying a resilience building grant. And probably the most challenging, because you have to think through a whole business canvas and think of resilience dimensions in communities and how it builds all together. But if I'm to think of a portal, let's say a system that we've built, and I think of the MIS system in this case in totality, that builds the resilience around first the users, the department itself, and in this case, I'll put community in context of the end users. The system we are building at policy level primarily serves to ensure that the government delivers the services at the right time to the right people and effectively and as most efficient as possible. So if I have to think of how the MIS system was built in South Africa, for instance, the tool itself has several modules first. It was built in a modular function where slowly by slowly we're able to build data coming from different portions. So there's a health promotion data, entomology data, foresight data, and most recently now what I'm trying to do is incorporate climate data into this, but it's built around the people around the system. As I've always told everyone in the workshops that I train, and I tell them, this system is only as good or resilient if the people who are going to use the system understand what's in the system, how the system works, and they're able to work without us supporting them in the system. And that is a catch that I always put up. When I go back to the provinces, considering when I was building this, I was building it at one of the province levels. Now I'm at the national level. And as technical advisors, we do not have any further support. Sustainability or the resilience has been shown that if you are not there, that's the measure of resilience. Will the system continue working? And that's what we look at. We look at it, I'm like, right now, from the touch of a button, I can see all the cases in the country. And this is 3 or 4 years after I'm not directly supporting the project. That means it has built a resilient dimension around it. And it requires a lot, because for the data to come from the entomology unit, to come from the information data office, to come from the finance side to be put into the system, and all this is different cadres putting data into the system. So that component of actually putting people at the center of building these tools, at the center of building these modules, answering their needs, that is the most important. And ensuring that capacity building around the system will actually lead to the resilience we are looking for.
Thank you, Sadiq. The chat is firing up with questions for you.
Thanks. Yeah, I will be
So
reading. We go to the next.
yeah, so maybe as we talk to Dr. Camille, you can respond to a few of those, and we'll come back to them. Dr. Camille, hi. How are you?
Hello, I'm okay. How are you?
I'm doing great. Your moment of non-modesty.
I don't know if I can be non-modest. I'm a mathematical modeler, and I work in Cyprus, which is in the Mediterranean, in Middle East and Europe. And I work with a climate science group. They develop models to assess climate change and also the impacts of climate change on human health and also animal and environmental health as well. So we try to develop mathematical models. I myself specifically am interested in vector-borne diseases and the impact of climate change on vector-borne diseases. We do work on Aedes albopictus, the tiger mosquito, Aedes aegypti, sandflies, Phlebotomus, eye helm, and leishmaniasis, and also recently ticks. How we work is just like Sadiq said, it's impossible for one person to do everything on their own. So we try to establish a network, but mainly with experts in the field, climate experts and entomologists and infectious disease experts, but mainly vector-borne disease experts, and try to understand the questions that they have in mind and develop models specifically to address these questions. So a lot of the research concerning model development is, I believe, this trying to come up with hypotheses, trying to come up with answers to questions that experts have. So not all of this necessarily solve problems immediately relevant to the public. Not all of these are supposed to do that. So it's a research, and it can end up just informing a laboratory experiment, which is totally fine. I do not believe in research targeted on impact. Research is there to answer questions, any questions. But on the level up, let's say, if you have a good question and answer, you can think of developing a tool that will bring the results of a model, either your model or somebody else's model, to the attention of the public or the decision maker or an expert. So I think this is where most of the discussion today and in this AGM meeting has been focusing on the CSI tools that are specifically focused on making predictions that decision makers can use to make an impact in the society, to relieve disease, to make interventions, and etc. So yeah, I think I'm trying to answer the first question now before you even ask.
Yeah,
If you let me
actually,
talk, I'll go on.
let me ask it. Let me ask it so that it's everybody's on board. All right. So true or false? Let's start there. True or false? Not all tools are meant to be used. As you said that you don't believe that research necessarily should lead to impact, right? It's to answer specific questions. So not all models are meant to become tools, end user tools. True or false?
True. That's true. Yes.
Okay. So given that, and you had started explaining it, in your view, what determines whether a model should transition to that stage and who should be involved in that decision?
Okay, I think the main determinant is the aim of the model. So if a model is developed specifically for the purpose of helping a decision maker to make a decision, such as what is the most disease susceptible area in this country? When will be the most risky season for malaria transmission, for example? What kind of intervention is necessary to reduce the cases to a minimum, etc. When a question is built, when a model is built with this aim, then it has a potential to go to the next step. It has a potential to be demonstrated and presented to a decision maker. So, but not all the tools developed perform that promise, which is quite fine. And sometimes this is also a part of the research. We learn from our experiences. Some models are slightly less optimally working. So that the indicator here is the data. So a model is developed with a certain set of data, but the data collection process should not be ignored just because we have a model. So a model should always make testable predictions, and data should always be collected in order to validate those predictions. And as long as a model does that, it validates itself continuously, then it should be taken to the next step, I believe. But then you'll realize that there are more than one models that fit the criteria. And then sometimes it is possible to confuse the end user, either it's the community or it's the decision maker with the results of many models. So what we are engaged with is I don't know which question does this answer, but I'll just go on. So what we are engaged with is what also Sadiq mentioned, I think, collaborative model development phase, which is basically we established a workshop where we collect, invite modelers to come together, and we have a question. So we say, okay, our aim is to predict this vector, the seasonality of this vector in this region using this type of data. So to my surprise, and I mean, it's a happy surprise, a lot of the modelers are very keen to develop, to answer such questions collaboratively. I believe the community wants to learn from each other and wants to demonstrate the capacity that the added value that they're bringing to the field, and also to compare with the others, how their predictions compare with the other models' predictions and how those compare to the data. So as a result of this exercise, I hope that we can develop like ensemble models, collective models, and show which model is performing well under what circumstances, although it was developed for maybe a slightly different purpose, and to basically get everyone at a common ground with data always there to validate what we are doing. We have done this one in Bologna in Italy last year, and hopefully we are going to do one this year in Cyprus, in Nicosia, on Egypti, for the risk of Egypti-borne yellow fever and dengue in the Eastern Mediterranean and Middle East region. Unfortunately for myself, what we can do is quite limited with the network that I'm acquainted with. So it would really be nice to expand this work outside Europe and the Middle East, and have a global perspective, maybe collaborating with modelers from everywhere in the world. But this is one of the wishes I think I have if I ever have a genie discovered.
You've both answered and asked my question, and I can see Adamu has also asked my second question, which is,
sorry,
obviously we are seeing a need. No, it's great, because we are seeing a need, at least from the discussion, that there's a need to also form a community of modelers, right? So that we have all these people working on all these models collaborate, so that we're not regurgitating work that has already been done and didn't work. We can supplement each other. I think the second step, maybe the further step of beyond just the need of, and Saidu's question was, how do you think this can work? Technical working groups that actually bring modelers together, and even from how you've done it in Europe, like, and you're seeing that now modelers are willing to work together. And one of the things we want to do within this community, even with the fellows we are working with, is actually bring together people who are working on these tools and seeing how they can collaborate. And from your experience, even in the small groups that you've done, how in your opinion can we get there? Just beyond needing to get there, how can we get there?
So I can share my experiences with the group. So far, what we have done was not just to bring the modelers together, but also the models. And we implemented everyone together using different platforms, not just R, Python, Fortran, C, Julia. And we put all of these together and in a shared repository. We haven't yet managed to share this publicly, but every modeler has access to it at the moment. And then we curate basically the models. We enable them for anyone to install in their systems, run them, and confirm the output, the results of others' models. And this is a great resource also for anyone who would like to use any of the models and would like to learn more information about them, how to use them, what are their assumptions, they work under what circumstances, etc. So I think these modeling workshops could help us build a repository of models currently, we have this under the umbrella of VECLIM, which is a vector-driven, climate-driven mathematical models project funded by Wellcome Trust. And we have an early warning support system associated with this, with the GIS platform and etc. But I hope that the main function of this platform will be to enable access to these models, to these model repositories, developed and expanded at the end of each workshop, each with a different question in mind, but will enable users to run the models with different parameters and hopefully will take care of the curation part. I came from a systems biology background, and what we had there was a biomodels database, which did just that. They would browse the literature extract the models, implement them, and try to replicate the figures from the publications. We can't do that. Unfortunately, this is a huge amount of work, but I think this is what we need to for the peer review process to work. Because when you get a journal publication, a manuscript to review, most of the work that we have is interdisciplinary, and not one person, not even three, can effectively review the promises of the models. You know, but with this framework, workshops, public code, curation process, and interactivity, I think we can take care of the reproducibility of the research without taking care of the accuracy of the predictions. So for that, we need data, and I wanted to emphasize that.
My last question is, allow me to throw you off a little bit because I hadn't shared. But now that you brought up the question on data, do you think that, or do you see risks around data ownership inequity, where modeling tools are applied in the global south but designed and controlled elsewhere? Is that something that you see? And how do we address that, especially now when we are trying to create a network, right? A global network. We're trying to be collaborative. How do we address that inequity?
I must be honest with you that I'm a bit confused about the terminology. So, but let me try to interpret what I
or
heard.
I can rephrase it.
I'll try, and
I'm
then
happy
if I'm
to
wrong,
rephrase it.
let me know.
Okay. All right.
Okay. So data ownership is a big issue, especially for biological data, for health data, for vector data that we use to validate the models. I do not have a solution for this, unfortunately, because anybody who invests a lot of resources to collect the data would like to publish it, or would like to have some benefit from it. But individual data sets are not really useful for modeling. You need to combine different data sets collected from different regions, made different times of the year, in order to develop a good model, accurate, predictive. So maybe non-research oriented institutes, maybe government, maybe municipalities, maybe NGOs could, or funding agencies could be utilized to fund only data collection. And modeling comes after we have a repository of data, like the data set. So I heard about this one, and I thought I should say this. The other one is I forgot. You asked. So you said something about equity.
Data inequity. So data is collected from
somewhere else.
South,
yes, that's also a big
and
issue.
then who owns the data? I mean, I think it's a conversation that's still it's a question that we need to keep asking as we go along. And as we develop these tools, like who owns the data we're collecting? You know, we can be doing this from a completely different geography, but we're collecting, like, for example, Professor Helen, I'm sure, you know, you are working across different continents even. Like, who owns the data you collect, and how does it go back to benefit the communities that you collect it from? Guys, I am out of time. The conversation is, Lana is looking at me sideways. What I would say is, first of all, Camille, Professor Helen and Sadiq, thank you so much for these wonderful insights. There are so many comments in the chat, and unfortunately, we don't have the time to go through them all, but I'm sure the team will get back to us on that. Camille, I've seen someone will be reaching out to you to join your your technical working group and workshop in Cyprus. So yay.
Of course,
But
I can write my email if anybody wants to contact me.
yeah, I think all our speakers should, if
Yeah.
with permission, please share your emails. There's a lot of questions coming up, but I think if I can maybe summarize the discussions that we've had today, is community is important. Collaboration is important. We need to include end users. We need to determine who the end users are and design for the end user. We need to factor in what we've termed as sustainability or resilience, as we have discussed it in another term, and how we can ensure that happens, and also build tools that can basically, work and continue working beyond the funding cycles and specific project timelines. So much has been discussed here. I think this has to be like an ongoing discussions in other sessions. And yeah, thank you so much for each and every one of you who participated. I can see we are more or less the same number that we started with. That's always great. It's been a long 3 hours, but yeah, thank you all for your participation. And I will leave it back up to Lana. Thank you.
Thank you, thank you. And I think the general feeling of everyone that has been joining since Sunday is it seems not enough time, yet we've actually quite had a lot of time together for the past few days. And there's even one more for tomorrow. And I would like to invite Angela to speak about tomorrow's event.
Hi everyone from Thailand, where it is 10:51 p.m. It's so good to see you all. Just a huge, huge thank you, first of all, to the speakers, also to Nkirote, Lana, and to those who I've been seeing on every single day. So we're used to seeing a drop off. We expected a drop off, but wow, you guys have really kept up the energy in this virtual AGM. I am so happy. And I'm looking forward to closing it out tomorrow with a synchronous conversation. So we are finally bringing together our in-person Thailand AGM, where the energy has also been really high, and to bring now this virtual space and to have our synchronous chat. We are pushing it 1 hour earlier than originally planned. So for those who already had it in your mind, it is pushed 1 hour earlier. I hope everyone has been able to get the calendar invite that has a new Zoom link. We've kind of been playing a little keep up with our tech. One of the lessons learned, definitely. If you don't have it and you are wanting it, please send me a message right now and I'll just make sure you get it. The conversation will be brief. We are only together for 60 to 90 minutes. And it really is a chance for us to talk about, okay, we've had these wonderful conversations online, in person. What's next? How are we moving out of this synchronous time during the AGM, and what's going to happen? So, spoiler alerts, we are going to be formalizing our membership. So, if you are inspired by the community and the conversations, we invite you to consider joining as a member, a CSIDNet member. And members will then also, very soon after signing their membership agreement, have the opportunity to submit a working group proposal. And we will be talking about that a little bit tomorrow. And then voting on which working group proposals you want to see. So if you are inspired by some of the topics that we've been talking about, whether it's thinking about your end user, thinking about whether or not a model should become a tool, what might be needed to make it into an appropriate tool, the whole range of conversations that we've been having over the last couple of days. We're hoping that some of these will be threads that will turn into working groups that will then continue the conversation and the activities and the collaboration over the coming year. So more to come. If any of this sounds interesting, please do join us tomorrow. I believe in East Africa it's 11 No. It's 3 p.m. So that's 11
7
a.m.
p.m.
No, 11 a.m. tomorrow, Nairobi time.
Okay.
So it's earlier in the day. I hope you guys can pop out for early lunch break or something like that. It's from 11 a.m. Nairobi time, and I think that is 9 a.m. West Africa. But
Yeah, 9 a.m. in Nigeria.
yeah, 9 a.m. Nigeria.
It's
Okay,
9 a.m. in
great. So I do hope to see a lot of you. And I think that's it for me. Thank you, Lana. Back over to you.
Thank you, Angela. Well,
Thank you,
similar to
Angela.
how we've been closing, feel free to say goodbye in your own language. Unmute yourself, show your face. Thank you for joining today. We did put in some links. If you can help us improve on the sessions, use the feedback form. And if you'd want to know more about the membership and couldn't join tomorrow, there's the sign up in the link as well. So, bye everyone. Thank you. Thank you.
Bye
Thank
bye.
you.
I've
Thank you,
learned some
Lana.
Thai.
Bye.
Kopunka. That means thank you
Yeah,
in
Angela.
Thai.
Bye. Teşekkür ederim. Görüşürüz.
Asante.
Yasu.
Thank
Thank you,
you.
Lana.
To Camille for this insightful.
Thank you to our
Thank you for the
speaker
invite.
Rosie
Bye-bye.
and
Thank
Dudu.
you, Lana.
Thank you. See you tomorrow.
Thank
Bye
you.
bye. Good girl.
See you tomorrow.
Thank you, Angela.